Okay. Dr. Monica Gramatges is a pediatric oncologist, a clinician, and a researcher with Texas Children's Hospital. We met her 3 years ago this month when our son Brian was brought in for treatment for acute lymphoblastic leukemia. So thank you very much for joining me.
You're welcome.
Today.
I'm happy to help.
Appreciate it. We don't have much time, so I'm just going to get started
Okay.
with a couple of questions on background.
Okay.
How and when did you decide that you wanted to be a physician and an oncologist in particular? Were there some influences or key events that started that for you?
Sure. So no one in my family is a physician. I am the first person to decide to go to medical school. And it wasn't something I knew I was going to do from when I was a little girl. It actually was something that came to me a little bit later. When I went to college, I was an art and art history major.
Oh,
so,
interesting.
Yes, I thought I wanted to pursue that as my passion, and actually was thinking about art therapy. So when I graduated from college, I went to Chicago and I did an art therapy internship. And that was working with older patients, doing art as a form of therapy to help them cope with...
Older patients meaning?
Elderly.
Like what?
Okay. Help them cope with what they are going through. There are patients with Alzheimer's disease, other kinds of dementia. So I thought that was going to be my career path. But in that internship, I really decided I wanted to be more a part of the decision making. I wanted to understand the pathophysiology better. I felt like I wasn't as much a part of the care team as I wanted to be. And I really decided, ultimately that I wanted to go to medical school. So I had taken some pre-med classes in college, so I had a few things I had to catch up on so I could actually apply. And when I took those classes, then I applied for school. In medical school, I started volunteering at MD Anderson for their children's art project, where I worked with children and families who were living with cancer.
Okay.
And I worked as an art teacher. So I was able to continue my art therapy there and really just fell in love with it. I had some patients there that were transformative for me in terms of the realization that this field would be perfect for the continuity that I wanted to have with families, as well as the diseases were interesting to me. I felt like there was a lot of good work being done, but a lot of work that still needed to be done. So that kind of drove me to pediatrics. And then in my pediatrics residency, I continued to do oncology rotations and really decided, okay, yes, this is it. This is what I want to do.
Okay,
so
very
that's kind
good.
of how it all
So you kind
played
of
out.
Okay, no,
Yeah.
that's interesting.
Yeah.
And then medical school. So I've never been to medical school. It seems to me like one of these things, like I don't know, like boot camp or some sort of almost like a rite of passage that is a big deal when you're going through it. But once you're done, I mean, everybody who's a doctor has been through medical school, and it's just
Right.
something you do. But when you're in the process of it, what do you remember what that was like? What did you find challenging, and what did you do, or what did you find particularly useful as a strategy or a technique to get through medical school?
Well, so I went to medical school at UT Houston, so here in Houston. And it's very timely that you asked this question, because I'm actually in the middle of facilitating a course for medical students to help them deal with the stresses of medical school.
Oh, okay.
So the issues around medical school are that you're given a lot of information that you have to assimilate and understand in a fairly brief amount of time. It's very competitive because everyone knows that you have to make certain grades and make certain scores to get the most competitive residencies. And everyone feels like they're not as smart as the person next to them. Everyone is universal, so it's clearly not true.
Yeah.
But everyone feels like they're struggling, and no one's willing to admit it.
Ton of stress.
It's a lot of stress. Yeah. And I think it's really easy to forget who you are and what made you want to do that for your life's work. And I think it's very easy to fall into a trap of the stress and just feeling like you need to study all the time and lose the things that make you fundamentally happy and make you who you are on the inside, and forget the things about medicine that are so rewarding and the reasons why we go into the field. So what I'm doing now is there's a course that we offer for both UT and Baylor medical students, the joint medical school course called the Healer's Art, and it's an elective, so they get elective credit for it, but for 5 evenings in January and February, we meet with students to discuss why we chose medicine, how we take care of ourselves when we're in medical school to make sure we stay healthy and remember why we're doing what we're doing.
Right.
And part of it is how to deal with grief and loss, which is a universal part of being a doctor, which is a really hard thing to do. And then how to find the awesomeness of medicine. It's called the awe of medicine. But it's a national course. It's actually offered across the country, and we feel like students who have gone through that course feel like it's made a huge difference for them in remembering why they are where they are.
Why they're there in the first
place. And also
place,
recognizing that they're not alone, that there's actually, everyone has similar insecurities and similar feelings of inferiority, but every one of us has a lot to give in our own unique way, and we're all kind of in this together. And mentor them in a sense, and to see what it's like to be a practicing physician.
Is the stress of, so I kind of relate it back to boot camp almost, where you're intentionally put under stress to simulate, what that might be like in a real situation. I mean, is the stress of medical school similar to, in some way, to what you face as a practicing physician?
I think it's totally different.
Really?
There's similarities, I think, in your clinical years. So medical school is structured, the first 2 years are primarily didactic, and the third and fourth years are more clinical. So in the sense, the clinical years prepare you for how to interact with people, how to efficiently and quickly elicit a history, and use deductive reasoning to understand or to figure out what a good differential diagnosis is in your plan. And those are all life skills that you need. But the book learning that you do during your first 2 years, I think it's important to have good study habits and to know how to critically review literature, but that seems to be a minor part of the just sheer rote book learning that you have to do in your first 2 years of medical school.
Okay.
And a lot of that information, frankly, is information that I don't use today. So
so it's maybe the
you have to learn it to pass your exams,
yes.
but it's not something that I have necessarily used.
And there may be something to be said for the ability to learn it and understand how to do it right.
Yes,
that
and
carries
there,
forward.
I think there are some basic pathophysiology things that you have to understand, no matter what field you go into. But I would say that depending on where your career takes you, there are certainly subspecialties where you'll never really use or need your biochemistry, for example.
Then do you think, just personal view, do you think that the structure of med school could be, like if you could wave a wand, would you change it so that it's more of the clinical and less of the didactic? Or, like how would you restructure that balance?
Think there are movements to change how medical school has been this way for a very long time, the way that most medical schools function. And I think that there are movements here to try to change that, make learning more interactive and less didactic, do more small group learning, try to make it less passive and make it more active learning, if that makes sense. Yep. And some programs have tried to integrate the clinical aspect of it earlier in the process, so you're not doing sheerly didactic learning the first 2 years, but have preceptorships in your first year or opportunities to actually see what's going on with real physicians as mentors very early in the process. So I think those are positive changes.
Yeah, I would imagine that would be beneficial, sort of reinforce what you're learning in an actual clinical setting. So you are not just a practicing clinician, you're also doing research. Can you describe briefly for the layperson what your research is and why it's important? Okay,
so my interest is in both leukemia and in cancer survivorship. And what my lab primarily does is try to understand genetic risk for cancer, but mostly therapy-related toxicities. So why some people who get chemotherapy or radiation develop severe side effects and why others don't, even though they've received the same therapy. So I'm studying different aspects of host factors, so things that make you, that might make you at higher or lower risk for developing these toxicities. And that applies both to a therapy for your first diagnosis as well as for long-term effects of therapy, but we see in our late effects or survivorship clinic.
Okay.
Yeah.
And you said it's your lab. I mean, is it you working on your own, or do you have several other people that you're working with?
So this is a new development. So it was me and just me for a long
Okay.
time. Now I do have a lab space. I have a technician in my lab. I have a fellow working with me now,
Okay.
who's doing some really cool work with cancer survivors and understanding pulmonary late effects of cancer therapy, which is interesting. And it's growing, but I'm a very new lab. So I was given my own space about a year and a half, 2 years ago.
Exciting. Yeah.
And I have a technician for a few years, and this is my first fellow trainee. So I'm kind of
Very cool.
a budding young investigator, if you will.
Now, so then how do you balance the clinical side versus the research side?
It is a tricky balance. The lucky thing for me, at least I feel very fortunate to be in research primarily because my schedule is flexible. So if I miss part of a day in the lab where I really need to get something done for an experiment, I can make up that time later in the day after my kids go to sleep, on the weekends, things like that. If need be, I have that flexibility.
Yeah, if something urgent pops up on the clinical side, you can recover on the research side. Okay. Can you, just shifting gears to ALL, acute lymphoblastic leukemia, which is what I'm most familiar with.
Sure.
I'll still sound like I'm incompetent next to you.
I
but
don't think so. You know a lot more than most parents do.
Can you describe ALL, sort of what it is, how it works for the layperson, and then as briefly and simply as possible how you treat it?
Okay, sure. So this is a little bit of how I would give a diagnostic talk to a family who's just learned that their child has leukemia. So the way I was taught to explain this, and I think we learn from our mentors, and then we try to pass on that knowledge to students who are studying under us, is to first explain that, of course, leukemia is a form of cancer, which not everyone knows that, so it's important to say that. And then to explain that it's a cancer of the blood and bone marrow. So it's a liquid tumor that begins in the bone marrow, which is the space that's inside of your bones. And inside that bone marrow, your body produces 3 types of cells. So your white blood cells and your red blood cells and your platelets. And your white blood cells are supposed to fight infection, and your red blood cells carry oxygen to your body and give you energy, and your platelets clot your blood. So when the inside of that bone marrow develops leukemia, what that means is that the white blood cells have stopped doing their job, and they're not fighting infection. All they're doing is making more and more of each other. And those cells don't have a purpose. They're just filling up that bone marrow with leukemia. And what that means is that the bone marrow is full of leukemia, and there's no space for the healthy cells to grow.
It's crowding out the healthy cells.
And in Spanish, I like to describe it as a garden that's filled with weeds when I talk to my Spanish-speaking patients, because that seems to be a good analogy. But we have to remove the weeds in order to let the healthy grass and flowers and trees to grow again. So
you got to be careful about how you remove the weeds, though, don't you?
Yes, you do,
Yeah.
because you can't help but killing some of the healthy stuff too, and that's part of the key. But when you have low platelets, because there's no room for the platelets to grow, then you might have bleeding or bruising. And when you have low red blood cells, you might have anemia and reduced energy. And then when you have low normal white blood cells, then you might not be able to fight infection very easily and get a fever and get sick. So what the chemotherapy does is it tries to remove those leukemia cells and allow the healthy bone marrow to grow again. And leukemia therapy is one of the longest therapies we have for any kind of childhood cancer, because it's about 2.5 to 3 years on average for most children. For ALL, for AML, it's about 5 to 6 months, depending on the kind of leukemia you have, dictates the duration of therapy. But the difference is that the AML therapy is given, it's very intensive medication given mostly inpatient, and you're pretty much neutropenic with a low white blood cell count for a lot of the time. So very high risk for infections, very intensive therapy.
That's AML.
AML.
Yes.
ALL is less intensive. It kind of goes more in a cycle of intensive, less intensive, intensive, less intensive, followed by a prolonged period of maintenance where it's not meant to be intensive. It's meant to be maintenance in remission until the therapy is completed. And we use a combination of different agents given at different time periods to attack the cancer from different directions and use different mechanisms to best achieve cures. We found that using one agent is less effective than using multiple agents.
Okay, excellent. This raises for me a question I've been dying to ask.
Okay.
Well, and when I sort of read up on the history of ALL in particular, which seems like a real success story, right? I mean, 60 years ago, long-term survival was like 0%, more or less.
Less than 5%.
Less than 5%. Yeah. Now it's approaching 90%. And it seems like there was a period of time, especially in the 1960s, when you had a lot of these, or not a lot, but enough doctors who started to try combination chemotherapy, 4 agents at a time, VAMP and MOP and all this stuff. Do you think that the type of research that they were doing, which seems like real breakthrough to me, do you think that that type of research is similar to what's going on today in terms of its scope or its ambition, or do you feel that we're more cautious today? I don't know. I mean, I'm just asking.
I think there was a lot more. I think there were more challenges during that time. Now, I was born in 1976, so I wasn't living through those times.
Yeah.
But I have heard from my mentors, my teachers, and also from reading. There's a fabulous interview on NPR with Vincent DeVita who talks about this and what his experience was like at the NCI. But I think there was a lot of stigma against people who were trying these therapies on children who were sick. No one thought that they would be able to survive.
Right.
It was a very, very high risk move that ended up paying off. But I think what he talks about and what others have talked about is that there was a lot of judgment being passed upon them for trying these therapies on children who are already so sick. If you can imagine the complications of leukemia therapy with the bleeding and the infection. I mean, these were very, very sick children, and there was much less supportive care available at that time than there is now. So it was scary, and it was a kind of a horrible thing. And these people were pioneers, but they were giving toxic drugs to children who were already very sick, and children, which I think people always are uncomfortable with. Now, that being said, if those first steps hadn't been made, we would never be where we are today, where we're curing over 90% of childhood leukemia. It's amazing. And our trials now, we're always very careful. No one ever gets a placebo. I mean, there's always a very careful, years-long discussion about how to design a protocol. It's kind of amazing how long it takes to develop and design a cancer protocol.
Do you think that slows down the process too much?
I think
it's necessary.
I think it's necessary. The problem with childhood cancer therapy is that there aren't enough children to get the numbers there aren't enough children diagnosed with cancer to get the numbers that you need. It's the difference that you want to detect in a short amount of time. With adult cancers, the trials can move more quickly because there are more patients diagnosed and more evaluable time points. With children, the only way we're able to do it is by having a national cooperative group, the Children's Oncology Group, or certain institutions that have a lot of patients. But that's how we're able to do it in the amount of time that we're able to do it. And the differences that we're seeing now in leukemia, frankly, could be quite small because the outcomes are already so good.
So good.
I mean, depending on the kind of leukemia, there are certainly trials for relapse disease or for poor prognosis leukemia where we're hoping for a bigger difference depending on the newer therapy. But for standard risk leukemia, you need a lot of patients to see a difference between 90 and 95% outcomes. So we're looking at other things like, can we reduce the amount of therapy for children who we feel like have such good prognosis that they may not need to have as intensive drugs. So there's a lot of other questions now that we're getting into that would never have thought of that in the 1970s, but now we're at that point where we can start thinking about that.
Yeah, we know how to kill the weeds. Now it's, can we kill a bit less of the grass and the flowers sort of thing.
Right, and how people have less late effects, because that's a big problem.
What do you see as the most promising or exciting areas of research right now in the field?
That's hard for me to pick because I'm biased.
Aside from your own, because I know that's up there.
I think there's a lot of really cool stuff happening with the CAR T cells, where you take patient cells and direct them, use their own immune system, harness that power to attack the leukemia. That's really fascinating stuff.
This is the one where they're modifying like measles and HIV viruses.
So there are those, and there are also methodologies where they are taking white blood cells out of a person who has a cancer diagnosis and then modifying those white blood cells to help them fight better against the leukemia cells. This is not something I think that will necessarily be translated to everybody, but in the relapse setting and refractory disease, it's pretty exciting. But there's a lot of things. I think what we're realizing now, and what one of my passions is that the price of the cure for all these patients is the chronic condition that patients are faced with when they're done. So it's wonderful to be able to cure cancer, but not at the price of having a debilitating chronic condition for the rest of your life. So what can we do to help understand what those late effects are better, prevent them, and try to mitigate those things so people can have long, healthy, happy lives, and not have to constantly go back to what happened to them when they were a child and how that changed everything for them.
There are a couple of questions that I want to ask you about some decision points that we had with Brian, some personal decision points. And I don't know how much you'll be able to say about this in your role as a doctor, but well, I'm going to ask anyway. The two big decision points that we've had, and I know other parents have this as well, is deciding whether or not to go on a clinical trial. And so we're on, I think it's 1151. 1131, okay. Which is replacing, on the injection of chemo into his spinal fluid, replacing high-dose methotrexate with a combination of
It's replacing
drugs.
Methotrexate with triple therapy, cytarabine and hydrocortisone in addition to methotrexate.
And so we opted into that study. And I know, one or two families who decided not to. How do you, and I guess the way we went through that decision is maybe not that important, but I'm interested from your perspective. I mean, how do you see that choice of whether to opt into a study? Do you think that should be something that's pretty easy for parents to do, or do you understand a reluctance to do it?
Yeah.
If you could, or maybe the other way to ask it is, if you, God forbid, if this was one of your kids, right? I mean, would you opt in for that sort of study or not?
Well, I think here at Texas Children's, we strive to treat all of our patients the same, regardless of whether they're on a study. So, and that's probably true of a lot of places, right? But the study comes with monitoring time points. It comes with oversight. And for those patients who decide not to go on study, we treat them basically the same in that we get labs at the same time.
Yes.
We get evaluations at the same time as we would if they were on study. And we treat according to the standard arm of the study. So we don't typically treat it using an experimental arm of the study. We use the standard arm for those who don't choose to go on study. I think what you're asking is highly dependent upon the study, because for the most part with leukemia studies, I've found that we truly, and this is the way it should be, we truly don't know which arm of the study is better. We just don't. And it's a question that we're asking that we hope might change therapy in the future. It may be that the experimental arms aren't better. We hope that they aren't worse. But we can't promise anybody, if they go on a study and they get randomized, that what they're getting randomized to is the best. There's always strong data, either data in relapse patients or preclinical data in animal models for the experimental therapies that we give. So there's always a really strong rationale for it, but how it's actually going to work in a human child who has new diagnosis of leukemia, sometimes we're surprised. And things that we don't think are going to happen, and things are better than we expect or not as good as we expect. That being said, depending on the study that you all did, we knew that there was good evidence for triple therapy. We knew that it worked. The hope was that triple therapy will reduce the neurocognitive effects that are associated with using methotrexate as a single agent,
Right.
but we don't really know. I didn't personally see a downside to that study, so it was fairly easy for me to present it objectively and say, we truly don't know which is going to be better. We don't think either one's going to be worse than the other. We don't really know, but there's strong argument to support the use of triples instead of the single agent. So if it were my child, again, in that similar situation, I don't think I would have too much of an issue with that.
Okay.
There are other protocols where the two experimental arms are dramatically different. I mean, it's like night and day, just the way the therapy is structured and what you get. One you get 4 inpatient admissions, one you get none. And those things I think are a little bit harder because the parents are agreeing to go on a study where one of the two possibilities, I mean, it could totally change what their next few years are like. And then it's a little bit, and I personally think that it's
tough.
a parental decision and you have to do what feels right for you. You want to look back on that decision and say to yourself, I don't regret making it, and I feel like I made it with the most knowledge that I possibly could have had.
Yes.
So in y'all's case, I tried to provide that to you by saying, look, as a parent, I want to know as much as I possibly could about this. I think it's not a bad idea at all to go get a second opinion about this and see how other people would do it, because it may be different from us, which y'all did.
Well,
and then it was
so
actually a very different opinion that you were given.
And that's
but I
the
think
second
knowledge
instance,
is power,
right.
right? So I think the more you know, the better, more comfortable you are with the decision that you make, and you know that you did what you feel was right at the time, and that's the best thing you can say.
It goes back to what you're saying, which is you try to get as much information as you can. You try to understand the potential consequences, and try to get to a place where you don't regret the outcome.
Right. And I think there's always going to be, there might be some slight variation if you don't choose to go on a study on what kind of therapy you'd receive, depending on what institution you go to.
Yeah.
Before the Children's Oncology Group was a Children's Oncology Group, there were actually 2 organizations, the Children's Cancer Group and the Pediatric Oncology Group, that merged to form the COG.
Okay.
And the way therapy was designed in those 2 groups was actually a little bit different. So former POG institutions and former CCG institutions sometimes treat patients who are not on study a little bit differently, depending on their history, their personal history.
I got you.
And some of it might play into that. But I think your point and what we talked about at the time was that nothing with leukemia therapy is set in stone. If someone's not responding well, we change tracks. We don't keep going down this like tunnel vision, this is what we're going to give you until it's done. If someone is having toxicities that are too much, just clearly they're not tolerating the therapy well, there's, written in the protocol, there's dose reductions, but there's also some variability there. We always have the power to take someone off a study and do something different.
Right.
Nothing that you sign on to at the beginning is permanent.
You're not going to pursue it just for the sake of the study.
Exactly.
Yeah.
So what I generally, going back to your previous question too, is when I talk with families is that you don't lose anything by agreeing to go in a clinical trial. You might lose an opportunity if you don't agree, and it turns out that you have something where you're eligible for an investigational study that you might regret later.
I see.
So it might always be a better idea to agree to participate from the beginning and make sure that you have all the opportunities that might be afforded to you depending on what you find out at the end of the first month or later.
Right.
In
still have
therapy.
all those previous
all the
options
doors are
available
open.
to you.
And you can always
Yeah.
close the doors later, but why not keep all the options open from the beginning? There are a lot of things we're learning from the biology studies, the samples that are sent for central review and for banking, that are really fascinating and amazing resources for researchers. We could learn more about Brian even like 10 years from now. Someone could find out something from Brian's sample and other samples that are like his that might drastically change what we do for certain subtypes of leukemia. It's kind of it's a shame to shut that door from the beginning. If you're at all amenable to the possibility of research, it's always good, I think, to leave that door open.
And I guess for us, there was another, this is not the main driving factor for our decision making, but there is also the recognition that some of the parents who came before us in these early days when it was really tough, were the ones bringing their kids in for these very experimental therapies.
Right.
And like I say, I mean, that's, we're not trying to experiment on him, but
yeah.
that is how the science progressed to the state that it is today.
That's how the field has grown and how we are today.
Yeah.
That's true.
Yeah, and I mean, I think about what those parents must have been going through. I mean, we've had some difficult times, but I mean, I just can't imagine what they went through.
I can't imagine either. It's amazing, the gift that they've given.
Yes.
I mean, every parent who agrees to participate in research is giving a huge gift to other children in the future, to researchers who want to learn more. It's a very powerful gift to give, but it's not right for everybody. And there are certainly families that I can sense pretty quickly that they're just,
it's not going to happen for them.
It's not really interested.
It's not their thing.
And that's okay, because we treat everybody the same. And it doesn't matter to me. I mean, I'm going to treat your child exactly the same. It's never going to matter after that day one, whether you're on a study or not. It's the care that you get is going to be the same.
Excellent. A question for you on maintenance therapy. We started talking about this before the camera started rolling, but this journal article in 2012 on the importance of adherence to the daily dose of 6-MP, which is one of the part of the backbone of maintenance therapy for ALL. So maintenance would last, I guess, for him for about 2.5 years for boys, right? And every day he's got to take this pill. What this study found was that kids who did not adhere to taking their daily dose were about 2.5 times more likely to relapse than the kids who didn't. It also found that the threshold for adherence was 95%. So if you didn't take 95% of that dose, you placed yourself at that greater risk of relapse. And that translates to about missing 1 day out of every 3 weeks.
Yeah.
And you place yourself at that greater risk of relapse,
it's
2.5
amazing,
times.
Isn't it?
It's incredible.
It's kind of
for 2.5
terrifying.
years. Yeah, and it's at a period of time when you're actually coming down off the worst of the treatments. Right, and your life is starting to return to normal.
Right.
Kid can go back to school. So I think it comes at a time when it's easy to forget how important some of this stuff is.
Sure.
So 2.5 times greater chance for relapse. You've got to take 95% plus of the doses. And then when you relapse, your long-term survival drops from, let's say, around 90% to around a third, 35%, 40%, something like that. So the stakes are high. So there's a question in here somewhere. Do you think that is widely known by the parents of patients? Because we're talking mostly child patients for ALL. I mean, do you think that is appreciated by them and understood? In other words, do you think we're doing all we can to sort of drive
I think
adherence?
when that study came out, the pediatric oncology world was pretty shocked that the adherence rate was, that you needed that high of an adherence rate. I mean, I think we all assume as physicians, incorrectly so probably, that when you prescribe a medication, your patients actually take it. As a mom, I know that's not true. And I have to say, I have a huge amount of respect for parents of children with leukemia, because the difficulty in getting those medicines in every day.
Yes.
I mean, my children have ear infections, and I have to tell you, getting that Augmentin in is such a bear. And with our busy lives, 2 parents working, 2 small children, it is really easy to forget that. And we are probably never gone through a 10-day course for an ear infection where we haven't missed at least a dose.
Yeah, right.
But of course, it's ear infection. It's not cancer. So that might change your adherence if that's what you're treating. But it's hard. People are busy. And especially in our teenagers, I think, it becomes very much of a challenge, because they are responsible for their own medications a lot of the time and for taking them. And, teenagers are teenagers.
They rebel.
And they rebel. But not only that, they forget. They have crazy lives. They're night owls. Their schedules aren't necessarily as the same as their parents are, and parents are busy. And I think when your child is independent like that, it gets even harder to remember. So we really try. There are several things I think we really try to emphasize the importance of adherence during maintenance therapy when we introduce maintenance towards the end of the intensive part of leukemia therapy, how critical it is to take those drugs. I don't think we fully understand what happens to those 5% who are, what happens to those, the paper quoted 44% adherent, we're not adherent.
We're not adherent, yeah.
I don't think the outcomes, like, are there degrees of adherence and what does that mean? I don't think we can say that people who are not adherent are going to relapse. That's not true, right? But certainly it increases your risk, and that's scary enough as a parent. You don't want to do anything to increase the risk of your child for the cancer coming back. So the more adherent, the better.
Yes.
And I actually tell my families now, 95% is what you're shooting for. So you really need to make sure you take it. And we talked a little bit about, before the camera started rolling, about the use of patient calendars and how y'all found that very valuable.
Yes.
And I think that's one thing that we do to try to help during maintenance, try to help families remember, as we provide them with a calendar with the medications on it. You can check it off every day, and it just helps to serve,
the
put it on the
patient
fridge,
calendar,
and just, that's a good way to remember, especially when there are multiple people, like maybe one parent's giving the medication in the morning and another one's giving it at night. So
one's on vacation or traveling.
Yeah.
That patient calendar
So
is
that
absolutely key, and not every institution does it.
Well, it's not. It's not required, right? So I mean, these studies don't say adherence is not something we're asked to enforce by a calendar. That's something we just do because we found, and a lot of that honestly is pioneered by our nurse practitioners who really feel like that's very important. Like Jelaine is a huge fan of the calendar, and she's the nurse practitioner that you all work with during your therapy. And when one of us starts doing it, then we all kind of do it because we very quickly realize that parents of children who aren't getting calendars recognize others are and want that. So we all do it because you can't do it for some and not for all. So all their providers have started really doing those, and I do think it makes a big difference.
Just a couple of quick ones before we wrap up. Given that the treatment protocol is so long, given two things. One, that ALL tends to strike kids, and that the treatment protocol is so long. It's not uncommon, let's say, for, by the time a kid is done with ALL, they will have spent half their life on the treatment itself, right? Diagnosed at 3.5, they finish at 7, half their life is on protocol. What do you think is the role, or how well established is the role of just sort of daily habits like nutrition in the treatment, right? Is it just the drugs, or does nutrition play some role, and how well understood is that?
It's not very well understood. I mean, we know that children who are well nourished do a better job of fighting infections. They have more energy. They're able to cope with the toxicities better. Malnutrition is a risk for toxicities, all kinds of toxicities, but certainly infection being one of those. We try to encourage our parents to make sure their children have a well-balanced diet. One of the things we struggle with, actually, we have two opposite ends of the spectrum, right? So we have the child who does not eat well, who is malnourished, who needs to be encouraged to eat more in whatever way we can. Our nutritionists are really good about ideas of injecting high-calorie foods into their diet, but also appetite stimulants, which sometimes we use. And then we have the opposite end of the spectrum of children who respond to steroids in a very unfortunate way, and they gain a lot of weight and develop obesity, which is, as we know, an epidemic in today's society, and a lot of our survivors struggle with childhood obesity. So for that, we also have our help of our nutritionist specialists, but we have a Healthy Bodies clinic at Texas Children's that sees those families, and it's actually a family approach, not a child approach.
Oh, right. Change the habits in the family.
Change the habits of the family. They have psychosocial help. They have nutrition help. They have exercise. It comes from all different parts of your life to try to change that trajectory. So I think it's probably an under-recognized or an under-addressed part of cancer therapy. Because so many times we're just focused on curing the cancer. that we forget about that. I mean, we've recently realized just having high blood sugar during the first part of therapy when you're on steroids is a risk for infection because hyperglycemia, kind of like you think about a diabetic, hyperglycemia is a risk for infection. It's not required that you check glucoses all the time during induction, but we've started doing that for our patients in induction because we want to capture those children who are at high risk for infections and control that high blood sugar from an early standpoint. So I think there are things we can do to help mitigate the toxicities or the problems that occur with nutritional issues, but it's really hard to tell a parent to make sure your child's having a healthy diet when they're on steroids and all they want is pizza and fried chicken. It's a challenge, and I think from a parental standpoint, it's hard to say no to your child when they have a diagnosis such as cancer, or try to make them do anything because you feel so bad for them.
Spoil them a bit.
Right. I think that's a very normal thing to do. So I think there's probably a happy medium where you're not super strict about it, but you use common sense, and I would hope that your physician would be able to help you navigate what that happy medium is for your family.
One more question from me, and then one from Little Man if we have time. From me, and this is a personal question, so don't answer it if you don't want. I'm asking kind of on behalf of my daughter, who's 11. And she's a very smart young lady. Like you must have been when you were 11.
She's a genius, and she
she's something else.
The cello.
She will someday grow up and probably want a family, and she'll probably want a career. And I don't have very good advice to give her on how to balance that as a woman, which I think is more difficult than it is as a man. How have you personally tried to balance career and family? Like, how much of that is a conscious effort that's planned versus spontaneous? How do you navigate that? What
really
advice
hard.
would you give to
So that's really, I think that's a really big challenge. One of the things is work in an environment where your community, your boss supports that support, and Dr. David Poplack, who is my section head, really believes that family comes first, and he's told me that any number of times, as he would any other faculty member. So he understands when you have to be away for whatever, a Valentine's Day party is coming up, or things. He would never fault you for doing those things. I think he understands it's a priority. I think I do a lot of deliberate things. I try not to work late and come home for dinner. So I make dinner for my family pretty much every night, mostly because my husband's a really bad cook. It's not because I love to cook, but I just I don't want to eat what he makes. So
you wouldn't inflict that on the rest of the family, would you?
So no, but I do enjoy cooking, so I do that. He does the dishes. We have an even distribution.
That's fair.
And if I have to work more, I try to do it when my children are sleeping. So I either stay home and I work on my computer after they go to bed, or on the weekends when they're napping. That's when I try to. So I try to, whenever time, it's already hard enough as a mom to send your child to a daycare or to a school and not be taking care of them all the time. It's hard. That first, that daycare drop off, it's heart-wrenching, that first one. So whatever time I have with my children, I want to maximize that time and not miss anything. I don't want to miss anything. So I think that's something that I do. And then I also joined physician support groups, which isn't really it's kind of women physicians who are researchers at our hospital. We get together once a month and we have dinner and we talk about work-life balance and how we handle it. So it's kind of a support group, but it's also kind of just a group of women who are doing the same, who are all struggling with having kids and having a career at the same time, which it helps to talk to other people, your peers, and have the support of your peers. And then I think I read a great article that one of my colleagues gave me recently, that you shouldn't think of it like a balance, like 50-50. It's kind of more like a spectrum, because there might be a day when my child needs me and it's 100% my child all the time. And that day is going to be with my kid. And there might be a next day when one of my kids relapses, one of my patients relapses at work. And that day is all about that patient. And I might work late that day and miss some of my personal family time, but it's because my work family needs me.
Yes.
So
it's more juggling than balancing.
It's more
almost,
juggling
yeah.
than balancing. And I think when you think about it that way, you feel a little bit less, oh, but I have to be, I have to make sure I'm evenly doing all my, you can't keep all your balls in the air at the exact same time.
Yep.
Some things are up and some things
Yep.
are down. And we're pulled in a lot of different directions, and you just kind of have to.
No, that's good. Thanks. Yeah, like I said, I know that's a personal question, but I appreciate it.
It's a hard question, and I think
it's an important
every
one.
person answers it differently, and I'm not sure if there's any one right way for everybody. But I think that Jada should know that it is possible, and that you absolutely can have a career and have a family at the same time, and that depending on how understanding you look for an understanding spouse.
Yeah. Yeah.
My spouse works from home a lot, which helps because we have that flexibility.
Okay.
So that's helpful as well.
Okay, last
Ryan
one,
has a
and this is
question.
from the little man.
Oh my gosh.
So little man,
This is going to be my hardest question.
Sorry, I think I'm making you a little bit late.
Oh, it's okay. It's fine.
This. No, it's unprofessional. We'll figure that out. Okay. You want to ask your question?
Okay.
Why do I have to eat when I take my Bactrim and not eat when I take my 6MP?
Oh, that's a very good question, Brian. Wow. So do you like to not? Is it not fun to not be able to eat when you take your 6MP? You're probably hungry. So your 6MP is a medicine that when you take it, it's better to take it on an empty stomach because food can make it harder for that medicine to get to where it needs to go. So while the Bactrim might upset your tummy if you took it without any food, the 6MP is the opposite. And if you take it with food, you can think of it like the food is soaking up all the medicine and you just poop it out. But if you take it on an empty stomach, then that medicine gets into your stomach and goes into your blood and goes and fights the cancer like it's supposed to. So that's why. It's because of the way the medicine works. Does that make sense? That's a very good question. Do you have any other questions for me? Are you sure? But, now's your chance. You can watch it on YouTube forever.
That's right. You good?
Okay.
All right. Thanks, man. Dr. Gramatges, thank you very much.
You're welcome.
Thanks
it
for your
was
time.
a pleasure.
Appreciate it.
I was
Likewise.
happy to do it.
Likewise.
Thank you.
All right.
Thank you.